So I'm Corinne. I'm one of the I'm a speech and language therapist at Papworth, and Henry was, you were kind of like the link person, so I thought it was really good for you to be here. So pipe up,
Yeah.
chat. So we were looking. You were, yeah. So I was looking at the use of ultrasound in assessing the swallow of people living with AT. So the beginning of the research, there were two key triggers for me looking at ultrasound. One was we used to do the French dysarthro, I don't know if you ever did it, but it takes a really long time. And the feedback I got was it was quite tiring, actually. And you see quite a lot of people, and sometimes the speech can be quite hard.
Yeah.
Yeah, with having to answer a lot of questions. So I now kind of sit with the dietitian, don't I? And I will listen to the speech. As you talk through about what you're eating.
Yeah. I can't eat with any hard stuff.
Yeah.
Because it's they're tired of chewing my jaw.
Yeah. So exactly. And so when you're sort of having to talk a lot and then, to get you to test your swallow at the same time, that's a lot to ask, isn't it? So the other thing was looking at the swallow and ultrasound. So one of the other things that people are quite anxious about is exposure to radiation with the video fluoroscopy. So what we thought was, could we just stick to one video fluoroscopy with the radiation, this low dose, but after that, then do the ultrasound, and that uses sound waves, not radiation. So those were the two kind of key areas. At the time that I was initially thinking about it, it was really ultrasound was not considered an ideal tool for this at this point. But what happened was we had COVID, and Papworth was at the kind of the front face of COVID, and basically I couldn't do fees and I couldn't do video fluoroscopy, both of the services, but I was really concerned about, I was finding a very disordered oral phase, very disordered airway. And so what I did was, in an emergency sense, was use ultrasound to enhance the clinical assessment. And so the pros of ultrasound is they can be done anywhere. So it's just like having, if you've had a pregnancy screen, it's basically, the equipment's available anywhere. It doesn't involve radiation. It also has a much higher frame rate. So a swallow is about a second with liquid. And actually, we use a video where the frame rate with the video fluoroscopy is 15 frames, so 15 little pictures, if you like, per second. Whereas with ultrasound, 175, so you're going to get a lot more data. One of the challenges of ultrasound is it basically, with ultrasound, the airway is full of air, basically, and air is problematic from ultrasound. It will interfere with the images, and the other thing, the thyroid notch will also interfere as well. So it's a tricky area to be looking at. But what happened was we set up an international group of speech therapists, radiologists, to look at whether we can advance the use of ultrasound in swallowing. So that was kind of where we went with that. You'll recognize the I don't know if you can see it, but the helmet bit, the straps. So what we did was Joan Marr led it. She's a senior lecturer at Queen Margaret University, and I met her through the international group for the safe rollout of ultrasound evaluation of the swallowing. And she's now set up with Alan Wrench, who's the engineer, a website looking at this, so you can gain further information. And then we basically kept with a very set frequency, and then basically probe that can be easily got, and basically it was a sort of side view. So when you look at this, I'll go up to this. It's probably easier here. So you've got your shadow here, your hyoid shadow, and then you've got the mandible, and then you've got the tongue, and basically they've now moved the technology on, so actually you can measure the actually see the tongue movement from the tip to the base of the tongue. You can't see the tip there. And what would be nice is if we can then do the ultrasound, we'll be looking at the tongue movement as well as the hyoid movement to then gain further information without it being too labour intensive. So we had 5 individuals. You were the first. And you linked with Joan Ma as well, didn't you?
Yeah.
To help with the feedback.
Yeah.
Yeah. So I've added an extra slide because looking at it, one of the things that I really want, that's the swallow there. There you go. Now this is better because this is 100 mils that we're seeing. We asked to do 5 mils, and that was tricky, wasn't it?
Yeah.
To get the swallow of the 5 mils, it was too small, and we kind of knew that at the time. But because Joan and Alan's equipment have been tested on 5 mils, we had to keep with 5 mils. But they have now since moved on, and they've done 100 mils, which is a lot easier. A few of the things that I kind of really thought about was how to better include people with AT in the research. And I think one of the things I'm really conscious of is the fact that as clinicians, we do benefit from doing the research in terms of our career. I think that's fair. And it would be really nice if actually you benefited as well. So with looking at it now, I think the role that you performed speaking with Joan Ma, giving that feedback, is there a way that we can have a role that is formalized prior to that, that actually then means that person gets, well, I mean, I'd give you a reference anyway, but, then actually they can then apply for jobs, because one of the difficulties is that it's really hard to get into the workplace, isn't it?
Yeah. So hard.
So hard, yeah.
Yeah.
Needs one-to-one. Obviously, we're one-to-one, even volunteering, they need someone with them at all times. And they're reluctant to take on even volunteers now. And he doesn't want mum with him all the time, or dad. So, yeah.
No, because you want to do your own thing sometimes.
Yeah.
Yeah. So it would be really nice if there was one thing that we do is we have the OT and we have the social worker, and they'll record your interests and everyone's interests at Papworth, and whether we could have a talent pool. So if, for example, with the headgear, which you saw a few slides ago, if one of the persons with AT that comes to our clinic has an interest in engineering, could they be involved in that? If someone's got an interest in digital work, could they be involved in creating the consent? Because I didn't feel like the consent was clear enough either. Is that fair?
Yeah. But for consent form, they should put the background in black background and use yellow as the front colour,
Right.
because recognised by vision impaired people.
Yeah, and see if we involved you properly, and and other studies, then you would say straight away that isn't gonna work. And that's really useful information.
Yeah.
And the other thing is, should we have used an iPad? Would an iPad have been better? Because you can adapt it a bit more easily.
Yeah.
Also about the drinking part of that.
Yeah.
Obviously, I mean, you can't drink, so people use the straw. Is that sort of part of it all the time now as well? People who can only use a straw, because Kevin can't hold any smacking his teeth on bottles, so he can only drink through a straw.
Yeah.
So is that ideal still for this study? People like what Henry done, taking part.
Yeah, and that was the thing we had to vary at the time. So what we found was the protocol, we did vary on it. Now, whether that impacted, you can't see the tip on it, but whether that would impact in the use of in the interpretation of the tip of the tongue, which again is a really good point. So those were the key things that I kind of thought about. So I think there is validity. I think it's a really exciting way forward, because one of the things is aspiration doesn't necessarily mean aspiration pneumonia. And as a speech therapist, I'm just a small part of that overall picture. I mean, you've seen today like how complex it is. And so we don't necessarily need to do a video fluoroscopy every time. There's lots of other assessments that we can feed into. So I think it has a way forward, and it would be nice, like at the next stage, to have more of a formalised role and more inclusive, because you can see just from what you've said now actually how much better that study would have been. So yeah, I hope that will make sense.